Just waiting for everybody to come in.
Watching the participant counter tick up in real time is something.
Wonderful. All right. Hi, everyone. I am Isabel. I am CEO of Renegade Research. Welcome, and thank you so much for being here. If this is your first time with us, we are a decentralized, patient, and caregiver-led, nonprofit 501c3 organization. We are driven by the vision to empower chronic illness patients through collaborative research with a mission centered on pioneering patient-led efforts that lead to scientific insights and improve quality of life for the community. Our work is made possible in part by individual donations, so please consider a contribution of any size for your year-end giving. The link will be posted for everyone, and you can also find it on our website. To stay up to date on our projects and events, subscribe to our newsletter, and I will leave you with our founder, Tess Fowler.
Hi, I'm Tess, the founder of Renegade Research, and I just want to mention that we are renegades because we have to be. We're rebelling against the systems, stigma, and status quo that have left people bedbound for decades without treatments and lacking social support. The scientists and clinicians here, I figure you must have a little bit of renegade in you, or you wouldn't choose to work on this complex situation. And for the patients and caregivers, we see you. We're fighting for you, and reach out to us if you want to join us. This meeting was born out of Ron Davis's molecular basis working group a few weeks ago. Today, we want to try to connect what was spoken about in Ron's meeting, the molecular findings and hypotheses, to the mechanical basis model and Brainstem hypotheses. And with the unique perspectives of everybody in this room, I hope that we can build a systems picture that can make disparate findings make sense and that can inform how clinicians should intervene in these conditions. So today, we're going to have Thomas Varley as our moderator. They are a neuroscientist and complexity scientist currently working at the Vermont Complex Systems Center at the University of Vermont, and in collaboration with the Allen Discovery Institute at Tufts and the Cold Regions Research and Engineering Lab in Hanover, New Hampshire. Initially drawn to complexity by an interest in the question of consciousness and how brain complexity supports conscious awareness, they have made contributions to clinical neuroscience, multivariate information theory, and network science. They hold a double PhD in complex system science and computational neuroscience from Indiana University, and a Master of Philosophy in Clinical Neurosciences from the University of Cambridge, where they research the effects of traumatic brain injury and disorders of consciousness on brain dynamics and functional networks. They write nonfiction on a Synergy Substack, which we'll put a link in the chat, and occasionally work as a glassblower. They're also on the job market for academic or scientific jobs in New England, and I can send a reference letter. They have done a brilliant work with our data analysis team. So I'm going to pass it off to Thomas now.
All right. Thank you, Tess. I am blushing listening to all of that. We are going to have 3 approximately 20-minute presentations from our invited speakers, and then we will have another hour of open discussion where, like Tess said, we are very interested in how we can connect, these sort of macro scale perspectives on neuroanatomy, mechanical deformation, to some of the molecular and cellular level models that were presented in Ron's meeting. So I will now introduce our first speaker, Jeff Wood. If you are a patient, you have probably heard Jeff's name before. He has been a tireless advocate for ME/CFS and ME/CFS research. He currently works on a neurosurgery research team, and he's most well known for solving his own case of post-viral ME and using that experience to build a model of the pathophysiology, which he calls the mechanical basis. And you can find him on his website, Mechanical Basis, where he has written about all of this. And so without further ado, take it away, Jeff.
Well, thank you, Thomas, for the wonderful introduction.
Looks good.
All right. So Today I'm going to be presenting on the mechanical basis model of ME-CFS. This is a model that I developed. And today, I am on a neurosurgery research team, as Thomas mentioned, but the ideas I'm presenting today are my own. These aren't the ideas of my employer. I'm not representing my employer or any doctor or any institution. So in terms of what is driving ME-CFS, what is driving all of these systems to malfunction? Well, the multisystemic nature of the disease suggests that there is a central regulator driving this dysfunction, and the brainstem is a good candidate as a regulator. We can see here how the brainstem governs or helps orchestrate many of the different systems that are dysregulated in ME-CFS. And Mike will go into the anatomy of the brainstem in detail a bit later. But here the question might be, okay, so if the brainstem is involved, how? What is the mechanism here driving the brainstem to become dysfunctional? Within this model, deformative stress is the problem. So deformative stress basically is what it sounds like. It's mechanical force is exerted on the brainstem, distorting its shape and disrupting neural signaling. And that could be the driving force of ME-CFS. Now, the idea of a brainstem pathology has scared a lot of people. It can be kind of alarming to patients and clinicians alike. For one reason, frankly, this is just a non-traditional perspective, right? This is not where the research has been. This is not where people's hopes have been. A pill is more appealing in some ways. But the good news is that neurosurgery is not a foregone conclusion at all within the mechanical basis model. There are some non-invasive ways of managing some symptoms and pathologies, and Brayden will be talking more about that during his portion. Okay, so some of the mechanical pathologies driving brainstem deformation are what you see here: craniocervical instability, Chiari malformation, intracranial hypertension, internal jugular vein stenosis, and cervical spine stenosis. So you'll notice how we have every type of mechanical force there, and then we have the pathologies next to that. So interestingly, these conditions tend to occur in people with connective tissue disorders. They tend to be kind of bendy. When we have these different mechanical forces exerting pressure on the brainstem or the spinal cord, then we get the brainstem deformative stress. Okay, so connective tissue breakdown. How can that lead to deformative stress? Well, when somebody has a viral infection, just as part of the innate immune response, our bodies release cytokines and inflammatory factors, MMPs, that cause a breakdown of connective tissue. And if the connective tissue breaks down right around here in the joints that connect the skull to the upper cervical spine, that's when we can get ligamentous laxity, leading to brainstem deformative stress. So when we look at the type of ME-CF onsets, yeah, a viral infection is the most common. Impact trauma is not uncommon. Now, it's pretty easy to see how an impact trauma could lead to connective tissue breakdown, right? You're in a motor vehicle accident, you have a bad whiplash. Okay, now your ligaments of your craniocervical junction are lax. Now you have craniocervical instability. Now you have brainstem deformative stress. It's easy to see the causal link there. The viral connection is a bit more mysterious to a lot of ways of thinking. But the viral infection is the most common onset. And it's a very important onset to consider, especially in light of the COVID pandemic. All these cases of long COVID are emerging, and many of these patients meet the criteria for ME. So the technical term for connective tissue breakdown is collagenylysis. So this is just normal. It occurs in everybody in response to viral infection, bacterial infection. It's not specific to viral infections. it occurs regardless of the infectious agent. It can also occur in response to mold exposure. So the mechanism of this, we have MMPs degrading the collagen, the elastin, other connective tissue proteins, contributing to ligamentous laxity, as with craniocervical instability. Now, the reason collagen occurs, the adaptive part of it, is it exists to relax barriers to accommodate the immune response. So its function is to, help the immune system permeate areas that it wouldn't otherwise be able to permeate. But this is a problem if you have vulnerable connective tissue, because collagen can get you not where it needs to, not only where it needs to, but also where it shouldn't. So there's plenty of evidence that that ME/CFS patients may be predisposed to connective tissue breakdown. Some studies say that 50% of people with ME are hypermobile. Other studies say, no, it's more like 15%. But, at any rate, the overlap is there. Okay, so let's go back to ligamentous laxity, because this directly relates to deformation of the brainstem as well as vagus nerve. So as we said earlier, when brainstem deformation is driven by ligamentous laxity, that's craniocervical instability. Now, we talked a lot about it deforming the brainstem. It can also deform the vagus nerve, and that'll be important in a minute. Also, Mike's going to talk a lot more about that later. Okay, so here we have the vagus nerve. It controls something called sickness behavior. And the term behavior is really unfortunate in the context of ME, because patients are so often, for so long, thought to have been malingering. They're just engaging in sickness behavior, they're faking it. But sickness behavior is actually a technical term. It, sorry about that. It refers to things that occur in all organisms, all mammals, basically. It's the process that happens when we're ill. So we get swollen lymph nodes, we get malaise, we get body aches. Sounds familiar. Part of ME/CFS is sort of this sick feeling. And when we consider brainstem deformation and vagus nerve deformation, we might be able to see how sickness behavior can be propagated by craniocervical instability the same way that all the other dysfunctions, immune system dysfunction, GI dysfunction, autonomic nervous system dysfunction, all of those can be driven by the brainstem. Also, each of those systems is also in part regulated by the vagus nerve. So we have some overlap in these central regulators, and they're all located in the same area of the body, right? Right up in the skull and upper cervical spine. So it's sort of, I guess it follows what you might call the principle of parsimony. Okay, so we can look in more detail into these pathologies that can contribute to brainstem deformative stress or vagus nerve deformative stress. So the first one, talked about it a lot, craniocervical instability can cause deformative stress on the brainstem and vagus nerve. Intracranial hypertension can also do this. It exerts mechanical pressure on the brainstem. Chiari malformation can also do this. It can cause, among many things, intracranial hypertension, which we'll see intracranial hypertension is a big player in brainstem compression, which is one type of brainstem deformative stress. We see cervical spinal stenosis also. And we see internal jugular vein stenosis. And this is an interesting one because it's not really brought on by injury. It tends to be something that people are born with, and people with connective tissue disorders are more likely to be born with this than people without connective tissue disorders. So here we have another source of connective tissue disorder flavored mechanical distortion of neural tissue, all occurring right around here. So here's a study, and this came out in 2020. It was the first of its kind, and it looked at intracranial hypertension craniocervical obstructions and also tonsillar herniation in patients with severe ME. So the results are kind of striking. It wasn't surprising, but maybe it's surprising to some people. I found this very interesting, and I was not surprised. If we look at this, quite a few people with ME have these pathologies. There were 205 participants in this study, and it was a retrospective cross-sectional study. It was performed at a specialist clinic, and the patients referred there all had severe ME/CFS defined by the Canadian consensus criteria. Interestingly, the way intracranial hypertension was measured was non-invasively. So it was through optic nerve sheath diameter measuring. That's an indirect measurement. There are invasive measurements, such as a lumbar puncture or intracranial pressure bolt. Those are more sensitive tests for intracranial hypertension. And given that, it is possible that this 83% number could be an underestimate. Also, for the craniocervical obstructions, those were determined by an MRI, which, good, it's an MRI, it can find things. But this particular type of pathology can also be assessed by other measures beyond an MRI. So it may be that this too is an underestimate. So there we had a case series. I was pretty interesting one. There were 3 women. They had cervical spinal stenosis. They underwent spinal fusions at the level of the stenosis. And in all of them, the ME resolved. It's like, okay, you know, interestingly though, one of them went on to develop ME again years later. So she had an MRI, and it was found that she now had cervical stenosis at the level beneath her fusion. So then she had that surgically corrected, and she went into remission again. So it's just another way in which mechanical problems can cause ME, and then mechanical interventions can solve the problem. One more thing on that. The mechanical intervention in this case was neurosurgery, but neurosurgery should be considered sort of a last resort. It's not something that anybody needs to rush into. The most important thing here is diagnostics and research. Neurosurgery is its own discussion, and it's not the goal. It's not a foregone conclusion for somebody that has these pathologies. This is an interesting case study. There was a patient with intracranial hypertension, and she had this due to transverse sinus stenosis on both sinuses. It was bilateral. She had a stent placed in each sinus, and immediately her ME resolved. The longest follow-up they had for her was 2 years, and she was still in remission at that point. So, with the brainstem as sort of the central regulator of ME, if you look at, there's a lot of literature showing that there are brainstem differences in patients with ME. So, total brainstem volume is larger, and this is also true in long COVID patients. This could reflect edema, inflammation, or deformation, or some combination of both. Another brainstem difference, reduced signal propagation during a Stroop task. So this reflects impaired intra-brainstem connectivity. The brainstem is not connecting well within itself. It's also large, and yeah, it's just not doing so well. Another difference in yet another study, that the brainstem is found to have impaired perfusion. So the blood flow there is not doing so great, reduced oxygenated blood flow. So now we have another problem found in ME patients' brainstems. So when it comes to this model, it can account for many observed findings in ME/CFS. It can account for every dysregulated system in the disease. The onsets are fairly logical, right? Connective tissue, the prevalence of connective tissue disorders in this population, viral onsets, collagen breakdown. We also have emerging research that the incidence of mechanical issues in this population may be quite high. In addition to published research, we have physician reports and patient reports, and people reporting that, yeah, we're seeing just an increasing number of mechanical diagnoses in this patient population. And there are some substantial improvements in remissions following mechanical interventions. So a big piece of this is something Tess touched on in the first part of what she said today. And that's that people with ME and their physician allies have lacked legitimacy for decades. It's been really hard. Part of the problem is because no biomarkers have been able to account for the illness. There are no agreed upon biomarkers, and the ones that have sort of been agreed upon sort of don't really explain things. And there isn't really a point of intervention. So the research here and the model here, it can legitimize ME as a physical pathology, right? Okay, your brainstem is bent and it's enlarged and there's not a lot of blood flow getting to it. Yeah, okay, so yeah, maybe you do have a physical illness. This model also increases the perception that ME/CFS is serious. Usually it's considered, well, it's just kind of an illness where you're fatigued, you're tired, you lie around, there's nothing really in your blood that can really account for it. That's kind of how it's been perceived. Now, with this model, it's really serious. Your brainstem twisting and bending and enlarging, and that's serious. Nobody can tell you that this is nothing. And we go back to the idea of a biomarker. And in this case, there could be multiple. If we can demonstrate a biomarker, it does so much for legitimacy and also for research, and just does so much. Okay, this one is sort of like an interesting point. It's kind of, I don't want to say controversial, but it's kind of difficult. So there are established interventions to treat these pathologies. Some of them are neurosurgery, some of them are not. The good news about there being established interventions, is that nobody needs to reinvent the wheel, but I'm thinking that the wheel should be reinvented. We need new technologies, we need new non-invasive treatments. That's just going to be really crucial for the future. But at present, we at least have some treatments. So what's next? I mean, where do we go? Okay, what do we do in terms of research? I think that one potentially useful form of research here would be to look into collagenylysis, because this is seems to be potentially a major trigger in this population, connective tissue breakdown. So that should be looked into. We would also want to examine the connective tissue patterns of patients with ME/CFS, and also want to zoom in on the ones that have had craniocervical instability. There's a lot of connective tissue work that can be done here. And that sort of ties into non-invasive interventions, which is a really big hope. So hopefully over time, we're going to have new methods to address these mechanical pathologies. All right. That's it.
All right, thank you, Jeff. So we'll have I see that there's questions popping off in the chat. We'll save all of that for after all of our three speakers have had a chance to give their talks. And so let's see. Next up, we have Michael VanElzakker. I'm sorry, Michael, if I'm not saying that right. Dr. VanElzakker is an assistant professor in the Division of Neurotherapeutics at Harvard and an neuroimmunologist with expertise in persistent central nervous system consequences. Oh, hold on, I lost the bio there. Mike uses functional and structural imaging techniques to identify abnormal patterns in brain inflammation and metabolism in patients with infection-associated chronic diseases. He facilitates collaboration among polybio research teams and serves on the board of directors of the same. He received a master's degree in behavioral neuroscience at the University of Colorado and a PhD in experimental clinical psychology at Tufts University. Shout out to Tufts. Yeah, so take it away, Michael.
Great, thanks very much, and I appreciate the introduction a lot. So, I'm basically going to do, what they asked me to do is kind of a walk around the brainstem. So I'll talk a little bit about, the anatomy of the brainstem and how it may be related to some of the symptoms in people that have been given the diagnostic label of ME. Remember, it's a list of symptoms that qualifies a person for the ME diagnostic label. It probably is, unfortunately, more than one way to get to that diagnostic label. It would be great if there was just one way and we could solve it with a single pill. But I don't think that's going to be what happens. But I think that this sort of mechanical basis is one of the risk factors, one of the vulnerabilities, and probably one of the drivers in maybe a really significant portion of these patients. And I think it deserves investigation. So this is sort of an image, a close-up image of the brainstem. It's one of those structures that is really evolutionarily preserved. So a lot of sort of health-related basic immunology reflexes that are sort of ancient and conserved across species are, the function happens in the brainstem. So it's really central to pain, central to the process of neuroinflammation, and central to autonomic functioning as well. So if we sort of focus in on the brainstem, this is actually a picture of my own brainstem, and I'm not a very good participant. I'm terrible at holding still in the scanner, so this is not as good of an image as you might normally see. So we sort of zoom in on brainstem, kind of right in the middle, right behind the sinuses there. And if we blow it up and then I Photoshop away some of the vasculature, this is sort of what the brainstem looks like. And we can superimpose a little bit of anatomy on the brainstem and try to understand a little bit about what might be happening if there's brainstem dysfunction, which again can happen for multiple reasons, including mechanical compression. One thing that I just want to point out is kind of on the left of the anatomical image there. You can see down at the bottom central canal, and then higher fourth ventricle, and then a little higher cerebral aqueduct. These are really thin, skinny canals through which cerebral spinal fluid flow. Much thinner than a pencil, more like the thickness of maybe like a cocktail straw or something like that. So you can picture a little bit of kink, a little bit of bend, a little bit of pressure on these structures, including from the cerebellum, which is right behind it. That would be Chiari malformation, causing a real significant disruption in the function of cerebral spinal fluid flow, which disrupts the rest of the brain function as well. So if we sort of zoom in right on dorsal brainstem, kind of below fourth ventricle there, and look at this sort of cluster of anatomy, there are a bunch of structures and circuits in really close proximity that are probably familiar in terms of the symptoms.
Sorry to interrupt. Michael,
Yeah.
we're seeing in the chat some people can't hear you. Is there some way you could speak up or turn up your microphone?
Yeah, I'm speaking right into my mic. Can you hear me if I go like this?
I can hear
How
you
about
fine.
if
I'm
I
just
just
looking
speak
at
without
the
the microphone at all?
Tess, Janet, do either of you want to chime in?
He sounds okay to me. Janet, if you want to mention in the chat or.
The
Talk-
sound did get a bit clearer.
Talk some more, Michael.
So I'm going back.
That's better.
Before. Can you hear me?
Yeah, that's a little louder.
Okay, great. So this is some anatomy, sort of a cluster of anatomy around the dorsal brainstem, kind of right below the fourth ventricle. And so if we sort of go one by one, highlighted here is the nucleus of the solitary tractor, or nucleus tractus solitarius. So this is the place where the vagus nerve enters the central nervous system from the periphery. I'll talk a little bit more about vagus nerve in a moment, but it's where the majority of cell bodies of the afferent or sensory vagus nerves sit. And you can see that if this structure is affected, a lot of the structures around it probably will be too. And I'll get a little bit more into that in a moment. Just as a quick teaser, remember that the vagus nerve is the one cranial nerve that extends outside of the central nervous system and innervates all of the trunk organs. So it densely innervates all the places that come in contact with the outside world, like the bronchus, the lungs, the gut, and it's very, very sensitive to inflammation in any of those places. A little bit lower is area prostrema, where this is a really interesting structure. For one thing, it's really central to the feeling of nausea. Not everyone with the ME diagnostic label has ongoing nausea, but a lot of people do. It's a really common, sort of subjective experience is ongoing nausea. And this is the structure that's sort of responsible for nausea and vomiting. It's also what's called a circumventricular organ, which means that it's a place where there is kind of a window in the blood-brain barrier. Normally, the vasculature of the brain is sort of wrapped in a barrier that prevents larger molecules from getting through. And this is a place where the brain can kind of sample the circulating blood. For example, when you have food poisoning or something like that, it's the reason that the contents of your blood make you vomit. So this is sort of a very simplified schema of the sensory vagus nerve. And remember, it goes in both directions. That's sort of important for the ability for it to be affected, and then the ability for it to affect autonomic function. In reality, the vagus nerve isn't really one nerve or even two on both sides. It's tens of thousands of branches. So if we just take, for example, this image of the vagus nerve in a rodent lung, one lobe of the lung. This is a stain showing, you can see all the branches just in the lung of a rodent. So the reason that it's so highly branched is so that it can be very sensitive to small amounts of inflammation, small enough that it wouldn't necessarily be detectable in circulating blood. It doesn't have to be. So there's a really rich literature showing that the markers floating around in blood aren't necessarily reflective of the markers that can affect the nervous system. It's so sensitive. It's got chemoreceptors at all the terminals, and it can detect small amounts of inflammation, which is the reason that you feel sick from a local infection. It still makes your whole body sick. So the sensory or afferent vagus nerve also detects catecholamines, like adrenaline, for example. So it's got these chemoreceptors on its terminals that detect the chemical milieu of the body. It also detects local immune signaling molecules. It surveys the gut microbiome. And then it triggers what Jeff had mentioned before, which is the central illness response or sickness response. And as Jeff said, in animal models, it's called sickness behavior because we can only measure behavior of animals. We can't ask them how they feel. But this is the sickness response where, in a rodent, they wouldn't run on a wheel as much. They wouldn't socialize as much or eat as much. They'd have a fever. And in humans, it also makes them feel sort of sick and feverish and very fatigued. And it triggers a central nervous system mirror response, which means that there's neuroinflammation on the brain side of the blood-brain barrier. This is important when we think about those closely linked anatomical nuclei in the brainstem that I'll get into in a moment. So the normal way that the peripheral immune system communicates with the central nervous system is through activation of immune cells in the periphery. On the other side of the blood-brain barrier, molecules that we've all heard of, like pro-inflammatory cytokines, don't easily cross the blood-brain barrier. They're somewhat large polypeptide proteins. They're lipophobic, not lipophilic, so they don't really cross lipid membranes very well. They don't get into the brain from the circulating blood very well. So there must be some way that inflammatory molecules can tell the brain that the body is sick, right? So when immune cells on the body side of the blood-brain barrier come in contact with pathogens, whether it's virus, bacteria, fungi, or even inflammatory molecules like pro-inflammatory cytokines, they activate the immune cells. The immune cells will release cytokines. And remember, because that vagus nerve is so highly branched, because it goes all over the body, only a small amount is needed to send a signal up the vagus nerve and say to the body, say to the brain, hey, the body is sick. So for example, if you inject a rodent with inflammation or something that mimics bacteria like LPS or lipopolysaccharide, the rodent will act sick in the way that I just described, unless you have cut the vagus nerve. And then it will largely act normal because the brain does not know that the body is sick. So this is a really important pathway for the feeling of being sick. And it allows local immune signaling. Importantly, for what Jeff was talking about, is that signaling does not have to be infectious. So in other words, something like compression, injury, shearing, bending, those sorts of things can also trigger the same sorts of inflammatory measurements. In fact, vagus is what detects whether or not you feel really full, whether your gut's extended or distended. And again, it triggers that mirror response on the brain side of the blood-brain barrier. And that activates microglia or glia. So about half of the cells in your brain are actually neuroimmune cells called glia. One example of which is a microglia. So it's a type of macrophage that's in your brain. And I'm going to talk a little bit about what they do so that it will make a little bit more sense why vagus nerve signaling might disrupt brainstem signaling, which then I hope will also kind of make the point that a physical a kink or bend or pressure or mechanical issues might also do the same thing. So if, again, pathogens or inflammatory molecules signal to the microglia, they activate. So they pull in their long, skinny arms. The cell itself gets sort of a thicker phenotype, and it releases glutamate, prostaglandins, ATP, cytokines, bradykinins, a whole bunch of things that excite neurons, including TSPO, which is measurable by PET. That's important because remember, the nucleus of the solitary tract was surrounded by all those other symptom-related nuclei. So if you dump out a bunch of neuroexcitation from either vagus nerve signaling or again from direct pressure, compression, then you'll have disruption of those nuclei's function. After these glia have been activated, they enter this state called primed, which is, it's a little bit maybe like, by way of analogy, like a sunburn. If your skin has been sunburned, suddenly it hurts even to just wear a shirt, right? So it becomes sort of hypersensitive. So in the context of this sort of mechanical model, it's a little bit like having an ongoing bruise in this area of brainstem, where the smallest amount of stimulus will now lead to a much more robust inflammatory response. So if you've got these structures that are surrounding the nucleus of the solitary tract, you've got a signal from maybe an infectious onset, maybe it's something inflammatory, again, maybe compression, that will cause the neighboring structures to have disrupted function. And some of those other structures include the dorsal motor vagus, which is a site of parasympathetic autonomic function. So, a lot of patients report autonomic problems. This is one of the autonomic nuclei in the brainstem. The dorsal reticular nucleus is really important for the transmission of inflammatory pain. So, the fact that people's, that myalgia from the term ME, muscle pain, joint pain, those signals can become exaggerated, meaning more sensitized, if this area of brainstem has been triggered by an ongoing provocation. The ventrolateral medulla is also involved in autonomic control of things like blood pressure, breathing, Again, these are things that are disrupted in people with the ME diagnostic label. The nucleus ambiguus, again, controls things like tachycardia, which in some patients with CCI can get worse when they go from lying down to standing up, probably because they have increased pressure that's then causing those glia to become activated and dumping out neuroexcitation. So that might be part of what comes from having these structures in close proximity. And I wanted to go back a little bit. You see down here in the bottom where it says central canal. Remember I talked about that skinny little canal through which the cerebral spinal fluid flows. The brainstem, actually, believe it or not, is not this static thing. It actually moves with the respiration and heartbeat. The image on the right is a deliberately accentuated image, okay? So I don't want you to think that that's what it looks like. The one on the left is more physiological. This is from the National Institute of Health. And part of what this movement that occurs along with heartbeat and breathing does is to move cerebral spinal fluid around the brain, cause the circulation of cerebral spinal fluid around the brain. Again, if you look at those areas like the cerebral aqueduct, fourth ventricle, and central canal, it's very skinny, and you need that sort of pumping movement to move the cerebral spinal fluid. The cerebral spinal fluid mixes with the extracellular interstitial fluid of the brain's tissue, and it actually flows along the vasculature of the brain. And a significant part of what does that is the movement. We know, for example, that movement of brainstem is disrupted by things like Chiari malformation or other forms of CCI. So that may be a significant part of what is driving symptoms in people with CCI or these sort of mechanical issues. I want to talk a little bit about some ongoing studies we have related to this, just to talk about kind of what we're working on in that field. If anybody wants to take a screen grab of this slide right here, I'll show it later, but this is sort of how you can get involved. What we're looking for is patients with surgeon confirmed CCI, hopefully traction confirmed. So we really want to be sure that people have CCI. We want to be very careful. We have, this is a difficult area, so we want to be really careful with recruitment. We've had to exclude a lot of people because a lot of people have, metal implants if they have these issues, and they may not be safe for an ultra high resolution 7 Tesla MRI, but this is a study that you may get involved in. And thanks to a donor to Polybio, we have some funds to help with travel as well. We weren't able to get everybody we needed just from the Boston area. So we're working with some scientists who specialize in brainstem imaging. We're really grateful to be able to work with Roberta Skloko, John Polimani, and Vitaly Napido, who sort of specialize in studying this unique area, which is difficult to study because of its movement and because it's so small. And so we actually use this large, high field strength MRI to study it. And what we're doing is mimicking a couple of existing studies, and we're doing it in CCI. So this is an example of a study from Laura Lewis's group, where what she did was, if you look at the upper left, she sent a pulse of magnet right below the fourth ventricle where that red arrow points. And what she can do then is, as cerebral spinal fluid moves through those canals behind the brainstem, she can measure the flow velocity and volume. The study that she did compared slow wave to REM sleep in the same people. What we're trying to do is to compare people with CCI to controls. Now, to be honest, it would be a little bit weird if we didn't find something here. I'm really hoping that we do, but this is the kind of thing that we need to get into the literature just to sort of establish a track record of serious research on the topic. So what they found between slow wave sleep and REM sleep is a significant, about a fourfold increase in the flow volume and velocity during slow wave sleep, which is interesting. And we're just going, our hypothesis is that this type of flow will be disrupted in people with CCI. Another thing that we're trying to do is to mimic this study from Ron Garcia and again Roberta and Vitali, where what they did was to use a vagus nerve stimulator in the scanner. Remember, it's the vagus nerve stimulates the nucleus of the solitary tract, which sort of relates to all these other structures. And what they did in this study was to put people in this ultra high field MRI. They wrapped a plethysmograph around their chest so they could monitor their breathing, and they stimulated the vagus nerve and showed in this study that during exhalation, the signal was stronger than it was during inhalation. What we are trying to do is show that the signal is going to be disrupted in people with CCI versus people without CCI. And we want to show a disrupted functional connectivity. Jeff talked about a paper from the Barnden group showing evidence of disrupted functional connectivity. And this is something that we're doing as well. And then last, we're working with both some neurosurgeons that do CCI and also Petra Klinge, who does surgery kind of at the other end of the spinal cord with tethered cord. And what she had shown is the tissue that she removes from the spinal cord, the phylum, is diseased and disrupted. You can sort of see the difference in the diseased phylum that she removes versus the non-diseased. And so what we're doing is having Dr. Klinge collect tissues for us that we're analyzing in a different way using spatial transcriptomics. So again, we're just characterizing these tissues. Why are these tissues disrupted? Why are the ligaments so damaged and not able to do their job properly at the top end of the spinal cord and holding up against pressure against the brainstem, and then at the bottom level as well. So just with that, I would just like to say thank you to everybody and just pop this up if people want to give us a call and see if they want to get involved in the study.
Awesome. Thank you. That's super interesting. And seeing the studies in action is really cool. There was some discussion in the chat about Q&A for people who are participating. We have, unfortunately, too many people to sort of open the chat to everybody. It would be unmanageable with almost 300 people. So if you want, you can find the Renegade Research or the Remission Biome group on X and follow along on there and try to have some discussions online. We will be doing another one of these sort of brainstem focused meetings sometime in November. Tess can tell you exactly when, because I don't remember off the top of my head. And so we might be able to get a little bit more interaction happening here. But just given how many people were interested, we're kind of having to keep it on a slightly tighter leash than we ordinarily might. So this brings us to our final speaker, which is Dr. Brayden Yellman. And so Dr. Yellman completed a BS in biology at Washington University in St. Louis and a Doctor of Medicine at the University of Texas in Houston. He completed a residency at Exempla St. Joseph in Denver, Colorado, and a fellowship in rheumatology at the University of Pennsylvania in Philadelphia. Dr. Yellman joined the Bateman Horne Center in January of 2019, and prior to working at Bateman Horne, he practiced at Intermountain Healthcare, diagnosing and managing complex health issues and illnesses in an outpatient clinic and consulting with network providers. He has developed and implemented a patient referral triage system to expeditiously identify particularly ill patients and provide them with rapid access, with a focus on underserved populations with prolonged waiting periods. Sounds familiar to anybody who's lived with ME. Dr. Yellman helped create a curriculum to educate primary care providers in recognizing, diagnosing, and managing rheumatological diseases. And so with all of that said, take it away, Dr. Yellman.
Thank you, Thomas. Just jumping in today, I'm a rheumatologist and internal medicine trained, but I have been focusing on ME, CFS, long COVID, and other infection-associated chronic conditions for the last almost 6 years now. And so I want to just throw in a clinician's perspective on evaluating patients with ME/CFS and where this sort of fits into the paradigm that I see in clinical practice. It's a lot more questions than it is answers today, but it's really designed to get everybody thinking. So I work at the Bateman Horne Center. We are a 501c3 nonprofit organization, and we care for the illnesses that we just talked about and all of their related comorbid conditions. We do occasionally contract with pharmaceutical companies and are involved in some clinical research, but none of that will be discussed today. And we don't endorse or recommend any specific products that are going to be talked about today. So I want to jump in specifically with the neurological and spinal manifestations that we see in hypermobile patients. As our two previous speakers jumped in on, we see or suspect that these type of issues are more common in those with EDS, or that there may be other hypermobile spectrum disorders that play a role here. And so this is just a list of things that have been considered in those patients, but I want to particularly highlight idiopathic intracranial hypertension, Chiari malformations, craniocervical instability, atlantoaxial instability, and acquired or occult tethered cord syndromes. These are all found at higher rates in people with hypermobility spectrum disorders. So as has been touched on before, we worry about incompetent connective tissues, that they may result in laxity of ligaments within the axial skeleton, within things like the peripheral nerve sheaths, and even the architecture of the myoneural and muscular end plates. Neurological manifestations may arise from associated weakness of these ligaments in the craniocervical junction and the spine, from early disc degeneration, and from weakness of the epineurium and the perineurium surrounding peripheral nerves. This ligamentous laxity in particular can then lead to nerve structure entrapment, deformation, and biophysical deformative stresses, as has been already discussed. These stresses may then contribute to secondary altered gene expression. They may alter cellular function, change neuronal function, and even alter phenotypic expression. And so this here is just to point out that we have been noticing or increasingly recognizing the formation of things like axon retraction balls and bulbs as a result of stretching or deformative stress injury upon neurons. And these are actually findings that are similar to those seen in diffuse axonal injury in the brain. Stretching of neurons causes pathological calcium influx, altered gene expression, and even apoptosis. So clearly, these forces are having a major effect, and it's sort of our determination to figure out what that effect is and how it fits into ME/CFS. This is a reminder to say that there are a lot of comorbid conditions that I think are interacting and contributing whenever we talk about any particular model of ME/CFS, and it's hard for me to see any one model without seeing the other comorbid conditions and the role that they play. So it's a quick reminder that nearly 1 in 3 patients with mast cell activation syndrome has a comorbid diagnosis of hypermobile Ehlers-Danlos syndrome, and that in some studies, we see that POTS and EDS and MCAS all very much cluster together. So a reminder about the effect of mast cells when we're talking about nerve structures and about EDS. And I highlighted 3 particular issues here. So mast cells produce inflammatory changes that release tons and tons and tons of mediators. In some studies, over 1,200 different mediators in connective tissues, and this can affect all kinds of organ systems. But specifically for the talk today, we do see, and there's been recognition of localized inflammation in the peripheral nerve, epineurium, perineurium, and endoneurium, with the releasing mediators activating nociceptive symptoms like peripheral neuropathy, like headache, like small fiber polyneuropathy, and of course, potentially things in the central nervous system as well. Mast cells and local connective tissue can cause microenvironmental changes that alter the extracellular matrix. They can induce IgE-mediated autoreactivity, and this can play a role in damaging connective tissues. It says rheumatological conditions here. I would not think of this as the adaptive immune response rheumatological conditions I used to treat so much as innate immunity in this case. And also we can see laxity of blood vessels, increased permeability of the blood-brain barrier, et cetera, with mast cell inflammation. So how does this all come together in craniocervical instability or atlantoaxial instability? So Of course, as been discussed already, this is a manifestation of incompetence or hyperlaxity of the ligamentous and bony elements supporting the cervical spine and the craniocervical junction. So it is CCI when it's C0 to C1, or it is atlantoaxial instability when we talk about C1 to C2. We then get increased motion and deformative stress at these sites. While CCI is traditionally thought to arise from neck trauma when we teach it to MDs specifically, abnormalities in expression, structure, and function of the fibrillar collagen can lead to these ligamentous incompetences or hyperlaxity. And then we get increased mobility at the joints. And so it's postulated that collagen or ligamentous incompetence may also be triggered by or accelerated by this mast cell inflammation that we're talking about. Everything is feeding upon everything here. So the increased mobility and instability that we see then can precipitate the deformation of the brainstem or upper spinal cord, including the ventral brainstem compression and basilar invagination. And this increased mobility or instability can also create traction on the vertebral artery or alter venous or CSF outflow from the cranium, as has been discussed. So what do we see in clinic? What are we looking for if we are suspecting CCI? And we really look for what has been defined previously as the cervical medullary syndrome. It includes things like headaches, neck pain, double vision, dizziness or syncope, vertigo, memory loss, tinnitus or altered hearing with ringing in the ears, dysphagia, dysphonia, altered vision, weakness in the arms or legs, numbness or paresthesias in the arms or legs, vomiting or emesis, choking, frequent nighttime awakenings, snoring, things like sleep apnea, changes in gait, altered sexual function, and altered menses. But I bolded headaches for a minute because that is generally, from a clinician's perspective, something that many people with ME/CFS will present with, and it's not always CCI. There's a lot to think about when headaches come up. And so I want to dive into that a little bit more. So for example, orthostatic headache is a major concern among our patients. There have been numerous studies, including a very well done one where there was Doppler ultrasound used to measure cerebral blood flow in patients on a heads up tilt table test. And this showed a clinically significant reduction in blood flow during the test in those with ME/CFS compared to healthy controls. That was 26% decrease in blood flow compared to 7%. And that's even when we don't see heart rate and blood pressure changes. So you would think of POTS in this particular case, but sometimes those adaptive responses of heart rate or blood pressure to a lack of cerebral blood flow fade out over time in ME/CFS, and yet we still see that lack of cerebral blood flow. Headaches are associated with this. So when I'm thinking about orthostatic headache, is a headache something that changes with position? Is it worse after being upright or after laying down? Does it develop as the day goes on? Is the headache relieved when we try to treat orthostatic intolerance with intravascular volume or other treatments? So I may give patients a trial of IV normal saline or increase their oral fluid and sodium supplementation and intake. We may use compression clothing or fludrocortisone to increase intravascular volume. We may use pyridostigmine to improve the venous return to the heart, or midodrine or droxidopa for peripheral arterial and venoconstriction to get blood flow to the tissues it needs to. Going back to that, so if we use those and symptoms improve, it might be orthostatic in nature. Alternatively, does a headache get worse after laying down at night? Do people experience a pressure sensation within the head, expanding in all directions after treatment with measures for orthostatic intolerance? If you increase intravascular volume and headaches get worse, you might be getting blood flow in, but it might not be getting out. Is there an underlying hypertension? Could this patient be experiencing worsening of that hypertension in the supine position? Can medications be exacerbating supine hypertension? So things that increase blood pressure or other vasoconstrictive decongestants, stimulant therapies, which are often used in patients who are particularly tired, for example. Do we have impairments of venous outflow? Do they need an MR venogram? And could there be dysautonomia-driven supine hypertension? Of course, we always want to think about CSF leak as well when thinking about headaches that are positional. Could the patient be experiencing a migraine headache? Do they have aura, phonophobia, photophobia? Is there a mast cell activation trigger with a secondary migraine? Do they have a catamenial component to their headaches? Is it related to the menstrual cycle? We see migraines as cause of headaches often as a secondary complication in ME/CFS, but I would not think of this as a primary complication. Though whenever someone comes in and says, I'm having terrible headaches, we do have to think about these secondary amplifications of things like orthostatic headache or CCI or some of the other things we're going to touch on. I see a lot of tension headaches. Does the patient have a connective tissue disorder, HEDS, that predisposes to increased neck tension, to bracing with movement and upright posture? Are they experiencing fight or flight overdrive, sympathetic overdrive with increased muscle tension, with increased dystonia or spasticity as a reactive response to hyperlaxity? Do patients' symptoms improve with heat, massage, stretching, muscle relaxants, acupuncture, Botox, or TENS? These are questions I may ask to try to figure out if tension headache is playing a role in their overall clinical presentation. Do they have a cape-like distribution to the pain that they have with radiation along the muscles in the shoulder and neck girdle? Is there pain with chewing or at their temporomandibular joint, or with palpation of some of the muscles in their face? Other things to consider: does the patient have headaches from sinus congestion, perhaps in the setting of rip-roaring mast cell activation syndrome? Is there sleep disruption that leads to headaches, perhaps even obstructive sleep apnea, causing headaches in the mornings? Is a patient experiencing a headache associated with viral reactivation-like symptoms that also can include fevers and arthralgias and myalgias, cervical lymphadenopathy, etc.? Could they be experiencing a mast cell mediated response to something ingested, whether that's a medication or food, or something that like a chemical sensitivity that they come into contact with, even via smell? Are they experiencing hypoxia? Could they be having hypertensive urgency, particularly in the context of sympathetic overdrive? Is the patient experiencing headaches secondary to excessive sensory processing? People don't tolerate bright lights, loud sounds, multiple sensory inputs at once, places like a crowded theater or a crowded restaurant, for example. Could they be experiencing a medication overuse headache, such as taking too many over-the-counter or prescription medications? In particular, could they be having rebound headaches when pain medicines for headaches actually are wearing off? This is actually really common in the non-ME/CFS population as well. And with things like hypermobile spectrum disorder, do they have structural TMJ abnormalities that could be contributing to headache as well? And then lastly, of course, when people enter the state that we call post-exertional malaise, headache may be a very prominent feature associated with this crash. And it's unclear if this is a separate type of physiological headache or if this is just an amplification of many of the things that we just ran through as a possible cause of headaches. Also important to remember that headaches can be due to non-ME/CFS related conditions. Glaucoma headache is not uncommon, giant cell arteritis, trauma, even stroke or venous sinus thrombosis. So I would also like to touch on acquired or occult tethered cord syndrome, which has come up just a little bit at the end of the last talk here. So this is an anatomical restriction of the normal movement of the spinal cord via that phylum terminale, where we have all of those changes that Dr. Klinge's study showed. And there is a tightening or tethering abnormality. So a healthy phylum is a fibrous, collagenous, and elastic band that connects the conus medullaris to the dural sac. And in tethered cord, the phylum appears to be morphologically altered with fatty tissue, dysplastic axons and nerve twigs, fat and vascular lacunae, or even congested veins. And so pathology is thought to be from forcible flexion stretching of the spinal cord against the phylum, causing tissue damage and repair, inflammation, perhaps a secondary mast cell activation, and or altered gene expression in the areas. And this will present classically with neurogenic bladder, lower extremity weakness and sensory loss, and lower back pain, but can also involve things like unsteady gait, loss of lower extremity sensation, migratory pain in the lower extremities, even restless leg-like symptoms, urinary frequency or urgency, as well as frequent urinary tract infections or dysuria, urinary retention. We see gastrointestinal dysfunction and problems, lower back pain, pulling sensations up in the neck and the craniocervical area, and suboccipital pain and pressure. And very prominently in clinic, we see that people will often lean towards toe walking and be unable to walk on their heels. So bringing this back and connecting it to HEDS, patients will frequently present with symptoms of tethered cord syndrome without traditional findings of a low-lying conus medullaris on imaging. And so morphological and biomechanical testing of the phylum in one study of 78 HEDS patients indicated limited elastic properties exposing the conus medullaris to non-physiological stress forces. Findings were compared to 38 cases of low-lying conus and tethered cord syndrome in patients who did not have HEDS. So HEDS patients may benefit from phylum terminale excision, even in the absence of a radiographic low-lying conus medullaris. I would like to also touch on the interplay of venous congestion syndromes or venous outflow tract obstruction syndromes. And we've touched a little today on idiopathic intracranial hypertension. So there's this increasing recognition that many with ME/CFS have symptoms of idiopathic intracranial hypertension. 20% of people with ME/CFS have elevated CFS pressures when we perform a lumbar puncture, but 85% of the ME/CFS patients who do not have this elevated CSF pressure on lumbar puncture still experience symptomatic improvements such as diminished headaches, improved fatigue, less brain fog after lumbar puncture and after removal of some of that CSF, giving them the symptomatic benefits we would expect in those patients with the elevated CSF pressures. Where do these obstructions arise from? Well, we think they can arise from abnormal venous pathology with venous stenosis or tortuosity and twisting, as well as from anatomical impingements, such as Eagle syndrome, such as CCI or atlantoaxial instability, such as spinal stenosis, disc herniations in the context of hypermobile spectrum disorder, and secondary inflammation from mast cell. Perhaps even venous congestion syndromes in the abdomen and pelvis, like May-Turner's or Nutcracker's, actually contribute to increased venous pressure within the skull. There are some interesting case reports where there are thoracic masses, for example, and when those thoracic masses are removed from a patient, their symptoms of idiopathic intracranial hypertension also improve. So the venous congestion from that mass in the thorax may actually be affecting what's going on in the tight areas of the skull. So people with ME/CFS and or HEDS may have uncharacteristic forms of IIH that do not meet our traditional definitions for elevated opening pressures on lumbar puncture, or who do not have traditional papilledema or swelling of the optic nerve. And it's postulated that many cases of spontaneous cerebrospinal fluid leaks and intracranial hypotension or low tension in ME/CFS actually arise from IIH as the underlying condition. So we have this dynamic condition where we're building up pressure. And then, of course, there is connective tissue disorder, there is mast cell inflammation, there are other pathophysiologies, and then we get a CSF leak. And then pressure builds up, and then we get a CSF leak. Further complicating the matter are positional changes. Supine versus upright can be entirely responsible for the presence or absence of specific venous or CSF outflow tract obstruction, or of even compression on sympathetic nerve bundles or on the brainstem at any given time. So not only do we have dynamic pressure buildup and release, but those things are changing with breathing, as we mentioned, but they're also changing with what position we're in and what is happening with our connective tissue support structures at any given time. So this really is a dynamic thing that we need to think about. So if we've identified this, if we have concern, we've ruled out other headaches, we have really strong concern for CCI in our patients, what do we start with clinically? And of course, there is no gold standard for this. This is sort of what I've been developing over time, and I'm altering this every single day. But I usually try to start with a functional assessment. Can we, for example, alter somebody's positioning, lay them down, put them supine? Can we alter the positioning of the surrounding soft tissue structures in relationship to their brainstem, and then see an alteration of the symptoms they're experiencing in the moment? And so that's where the idea of things like cervical traction and cervical stabilization come into play. So I will often start with over-the-counter cervical stabilization devices, some of which that can be adjusted for good upright support. They were never really designed to create traction, but when you adjust them, you can create some traction by putting force through the mandible. And by doing so, try to actually change the position in which they are sitting or they are supported. And does that change any of their symptoms in the moment? So we have used everything from inflatable cervical collars, which can help some people, to things like the Aspen Vista multi-post. We sometimes use a soft cervical stabilization collar. It looks a lot like a travel pillow. The idea there is not that it's creating traction, but it does hold the head in a supported position. And if you do that for, say, a 24-hour period, does a person, as they're upright, not experience the same fading or worsening of symptoms as the day goes on, fading of their energy, fading of their capabilities, fading of their cognition as the day goes on? It's a really interesting diagnostic test, and it can help when there is a vertical component to their CCI, but not all CCIs. A lot of motion and a lot of different planes may not be supported by this, but it is certainly easy to implement and worth a try. Now, I would never say to do that every day all the time. You would then worsen or weaken the musculature in the cervical area, and that instability will ultimately become worse. So we only do this 1 or 2 days at a time. Sometimes when it benefits people, we may have them wear a soft cervical collar for 3 to 4 hours a day, but then also ensure that they're doing physical therapy to strengthen that cervical musculature so that instability does not get worse. It is really helpful to remember that doing this traction in an upright position seems to be more likely to elicit benefit because it's often the upright position that people don't function in. That's often the position in which the neuroanatomy is arranged such that they are going to be more symptomatic. So things like supine cervical traction, while they can sometimes help in our patients, is not generally where I first start, even though that's traditionally in the physical therapy world what is used. Deep water traction is this idea of putting a flotation device around one's neck and going into the deep side of a pool and sort of floating with the flotation collar, creating that traction pressure. And it's been interesting because I think you get less anatomical translocation, obviously, on the sort of external musculature and connective tissue than you would with something like an Aspen Vista multipost. And yet sometimes people who do not respond to a lot of traction with these other devices will see a giant response in deep water traction. And so it begs the question, is there something about the density of neuronal tissue and how it floats in water as compared to the surrounding soft tissue structures, to bone, to ligaments, et cetera, that allows for more internal translocation? Maybe there are other reasons for that, but I've certainly seen clinically that patients may see in this particular circumstance that their symptoms can significantly improve. Now, can people live in a pool like this? Of course not. This is a sort of a diagnostic measure to say, hey, is this really relevant? Is this really what's going to improve your symptoms? Is this something we need to pursue further? Keep in mind that traction can trigger or worsen symptoms. Just because you shift the brainstem's position doesn't mean you're shifting it into a better position, right? You can trigger nausea. You can push on those areas that we were talking about in the brainstem before, create worsened headaches. You can create or exacerbate muscle spasms or dystonia. Your body is trying to hold your head in a fixed position so that it doesn't continue to exacerbate these neurological irritations. These can even trigger post-exertional malaise. I would also say that this can be a diagnostic test for concurrent tethered cord syndrome, because you have one confluent system here. And if you've got anchoring of the spinal cord at the base of the spinal cord, and then you're pulling in the upward position, in an upright position on the other end of the spinal cord at that craniocervical junction, you're creating more tension in that spinal cord, and that may bring out or accentuate symptoms of tethered cord syndrome, including the urinary symptoms, low back pain, lower extremity weakness, gait disturbances, or even the inability to lay down with your legs extended. You almost need to pull your hips and knees up into flexion to avoid that tension. So it's pretty interesting as a diagnostic measure for that as well. How else do we diagnose CCI? This is always evolving, right? But in the clinical world, we are struggling to find the right things to do for people. There is no gold standard here. I think it's pretty clear that upright imaging is superior to supine imaging when we can get it and when we can get a good image quality, which is a big if. But we are trying to assess what the anatomy is like when people are upright and the most unfunctional. Dynamic flexion and extension views are critical to identifying some of this pathological anatomy based on positioning. And a lot of our imaging centers are unfamiliar with protocols and correct positioning to get people into these things. And of course, they're provocational, right? Putting people in flexion or extension makes their symptoms much worse, and people get scared to keep them in that position for the duration of an MRI. Dr. VanElzakker couldn't hold still even without CCI. So can you imagine being put into this position otherwise? It's why it's so hard to get good imaging. And very few radiologists and neurosurgeons are even trained in appropriate evaluation of these conditions. I can't tell you how many times, really almost every time, I get imaging that is positive for CCI, and our neuroradiologists or our neurosurgeons pound their fists on the table and say, there's nothing here. It's normal. And then when you take this to somebody who is familiar with these conditions, you find out, no, it's definitely not normal. Well, are those particular individuals, are they seeing something that's not really there? Do they have a predilection to just see this everywhere? Maybe, but then we go and we treat the patients and they get better. So I don't think that's what's happening. Some of the things we can use are upright brain and C-spine MRI with flexion and extension views, a 3T MRI brain and C-spine MRI with flexion and extension views. Really excited about that 7T MRI that you were talking about, Dr. VanElzakker. We sometimes use upright cone beam CT with flexion and extension, or a rotational CT scan. Those CT scans are really good at looking at atlantoaxial instability, is my understanding, not being a neuroradiologist myself. We also look at a 3 Tesla MRA of the head and neck and a 3 Tesla MRV of the head and neck to see what is going on with the vasculature as well. And then additional screening for tethered cord syndrome. And of course, formal ophthalmological exam to rule out papilledema is important. Ultrasound of the optic nerve sheath, as was touched on earlier, is another intervention that is not common or easy to find, but could be helpful in this case. What do we do to diagnose tethered cord? And do we have to do this at the same time as we're looking for CCI? Well, we sometimes start with urodynamic testing. We're really looking to see if there are any features of neurogenic bladder. Not everybody with tethered cord will have it, but when you have it, it really increases the likelihood. Somatosensory and motor evoked potentials, not widely available in the United States, but really helpful when you can find them. And then, of course, a 3T prone and supine, so on the stomach and on the back, lumbar spine MRI. And what you're really looking for, if there's tethering, is that the conus should be shifting with gravity when you switch from the stomach to your back. And if it moves by less than 25%, the suspicion for tethered cord goes way up. A lot of these imaging protocols may show tethering cord, but many of them will not. You won't see the actual tethering, but you see the lack of movement and some other kind of associated findings that increase your suspicion for it, which is why the additional testing from urodynamic testing from somatosensory and motor evoked potentials is helpful. Why even a trial of traction with elicitation of worsening of the classic triad of symptoms is important before you would ever consider a neurointervention, for example. So what do we do for management and treatment of these things? Much like was talked about before, we don't necessarily recommend everyone jump right into surgery. These are major neurosurgical interventions, and there are a lot of complications associated with it. And I would also point out, and I think I touch on this again a little bit later, is that this is, from a clinician's perspective, we've seen a lot of people who have had this done. It is hard for me to believe that surgical intervention is a full cure for ME/CFS and all of its comorbidities related to EDS, to mast cell activation, et cetera. I see people improve tremendously, 80 or 90% better. They gain back most of the function of their lives sometimes. But ultimately, if they push themselves hard enough, you can see them end up back in PEM. You can see them in a mast cell flare. You can see their dysautonomia return. What happens if there's another viral trigger for inflammation, right? What happens if there is a disc herniation below the level of a cervical fusion, for example, and now you have more neuroanatomical impingements? This is always a dynamic situation. And so this may be for some people the intervention that changes their lives, but I still don't see it as a full, complete cure in the patients that have benefited from it, in my experience. So
sorry to interrupt, but in the interest of keeping everything on schedule, can I ask how much longer you've got on more slides?
About 5 minutes.
About 5 minutes. Okay, yeah. We'll get to the end of the talk, and then we'll go into the Q&A section. And we've also got part 2 coming as well. So if you have more stuff you want to cover, you're also, welcome to come back for that. But, if you can wrap up in 5 minutes, that would be awesome.
So for conservative management from a clinical perspective, we often start with physical therapy protocols like the Muldowney physical therapy protocol, which is used in hypermobile EDS. It's recommended by the EDS Society. Additional specialized physical therapy from people evaluating people's biomechanics. Specialists in this area can add to that protocol, because certainly that protocol as a one-size-fits-all is not appropriate. Is appropriate, but needs modification for people experiencing this. Upright cervical traction and support, and avoiding exacerbating factors. So a lot of times when there's deep cervical tension, we may need, or people may be inclined to get Botox to relieve their headaches, for example, or use muscle relaxants. And that is a double-edged sword. That may relieve tension and pain, but it may lead to worsened instability that actually exacerbates your CCI symptoms. On the other hand, when we really struggle to diagnose CCI on a clinical perspective before we send people into scanners, or before we know if we can even get access to the right types of scans or to the right types of neurosurgeons, we may have people, or they may end up undergoing Botox or using muscle relaxants and then forming cervical traction. And all of a sudden, that dystonia and spasticity and tension that they have that wasn't allowing anatomical translocation is no longer impeding that anatomical translocation, and you get an effective diagnostic cervical traction test. And of course, we know that there are cervical fusion surgeries that are designed to place things back where they need to be and reduce these anatomical contributions. I won't dive into that too much for the interest of time here, but I think it's worth mentioning that many times conservative treatment is all that is necessary for some of our patients. So I have had, and I can think of one patient in particular who really stands out, where she spent less than an hour on her feet upright per day until she started performing cervical traction with a cervical collar. She would do that for approximately an hour a day, and it would relieve some of her symptoms, and then started layering on physical therapy, specifically in the cervical region, but also throughout the entire body to support the entire biomechanical chain via the Muldowney physical therapy protocol. And before long, she was back to working. She actually was able to perform work at an 8-hour workday, as long as she continued to do traction every morning and then add in the physical therapy. If she moved away from that for a week or two, things would fade back and she would instantly lose her ability to be upright, and she'd be back to less than 1 hour of upright activity per day. It's a fascinating case to keep track of. And she's been in that cycle now for over 2 years. Hard to say what the natural progression will be over time, but so far she's been able to manage that conservatively. And of course, we all know that tethered cord release is another viable option for treating tethered cord. What I really want to mention here is that sometimes we consider a tethered cord release without considering looking at the CCI. In other words, if you relieve that tension at the base of the spinal cord, does that allow for the malpositioning at the craniocervical junction to shift without that tethering below? And is that enough to at least allow for physical therapy, cervical traction, other conservative measures to remove the major impact of CCI on those people's lives? And I have many patients who've had a tethered cord release in the context of neuroimaging confirmed CCI or AAI that now are managing their CCI or AAI and not having significant post-exertional malaise, having huge improvements in their functional capacity just as a result of the untethering of their tethered cord. So just briefly, there are these ideas of prolotherapy, platelet-rich plasma, and posterior stem cell therapy or percutaneous implantation in the CCJ ligaments. These are not really evidence-based by my understanding, and they have a lack of peer-reviewed data. I've seen them done on several of my patients, and I've never seen anyone improve from that. I know there are case reports where people do improve, and it makes me wonder, are those people full-on ME/CFS? Are they maybe HEDS without ME/CFS? What's going on in those cases? And so I would love to see more actual real research on these interventions, because we need more conservative therapies. So just some questions I want to finish up with. Where do I start as a clinician? What are some of the things I think about in the complex of all of this? So as we stated, many patients have concurrent CCI-AAI. They have tethered cord, they have IIH lag, pathophysiology, all at the same time. What are my clinical priorities when I see a patient? Well, I don't start here. I honestly don't. I start by trying to break the cycle of post-exertional malaise, getting people pacing. I try to get mast cell activation syndrome in remission, prevent progression, stop things in its tracks. I try to reduce symptoms of dysautonomia, whether that's orthostatic intolerance, GI dysmotility, via behavioral interventions, via pharmacological interventions. I try to calm the sympathetic nervous system or reduce environmental sensory stimuli influences. I try to improve metabolic deficiencies. We're starting to get some tools for that. And it's when a patient hits a wall, when there's really not many other further clinical or functional improvements that we can make. Maybe we've made improvements with all of these things we've done before, and yet the patient's functional status just isn't moving much. That's when I really say, is there something upstream here that is holding that patient back, that specific patient back from moving forward here? And are they ill enough? Are they severe enough to actually warrant the risk of possible neurosurgical intervention? If they're still able to have quality of life on a part-time job, how do you balance those risks out? Are they severe enough that it is actually worth going through a surgical procedure? When is it too early to look into this thing? When is it too late? Is there a point in time when people have had so much neuronal damage that even diving in here doesn't make sense anymore, that we don't expect significant improvement? I'm always asking myself, can we manage this entirely mechanically, like we said, via traction, via physical therapy or support? Can we manage increased intracranial hypertension with pharmacotherapy? We have drugs like acetazolamide and topiramate that reduce that intracranial pressure. I just learned this last weekend about using factor Xa inhibitors or pentoxifylline to sort of help in venous congestion syndromes. Does CCI or AAI improve or worsen when we change intracranial pressure and CSF venous swelling around structures like the brainstem, right? If you decrease pressure in this tight area, now is the brainstem shifting its anatomical position? Are the cranial nerves being less impinged on or more impinged on? Is the brain sinking more? Was it cushioned by all this intracranial pressure? Anatomical structures change positions when we change these pressures. And so we may think we're doing a good thing reducing intracerebral pressure, but we may be having secondary consequences there. Can we manage CCI AAI by untethering a tether cord only, as we just discussed? And this is my last slide. So are there cases where we suspect craniocervical instability or atlantoaxial stability or tether cord or IIH from the beginning, where we should immediately dive into anatomical evaluation and possible management? And I can say I have not ever really done that. I have never started diving into that. I always start with pharmacological and behavioral interventions first, but maybe that's not right. Maybe we'll learn more about that. Am I taking too long or too many numerous attempts at pharmacotherapies and behavioral interventions where I'm allowing for worsening or progression of nerve damage that may lead to more profound or permanent disability or dysfunction over time? I don't think we know the answer to these questions, and it may be different for every single patient. What do we make of reports of cure from neurosurgical intervention? And I really, as we touched on before, I'm convinced that CCI AAI may be the predominant driver of symptoms and of PEM in many patients with ME/CFS, but certainly not all. And eliminating this significant mediator of illness may improve their lives in exponential ways. And yet I don't know if that's equivalent to a cure. I've seen people with the PEM threshold be widely expanded. But ultimately, if you push hard enough, it's not really gone. People can fall back into ME/CFS symptoms with excessive exertion, worsen MCAS, with viral infections, with motor vehicle accidents, disc herniations, other venous impingement or CSF leaks. And it's hard for me to believe that the entirety of the metabolic and immune pathway perturbations that we see as potentially causes and also effects of this illness, that they're all gone, that they don't still exist in the background, even if we're not actively poking the bear, as it were, with these neurological structures. So these are really my thoughts. They're ways to look at this, and certainly not definitive by any means, but meant to spark some discussion. So thank you for your attention. I apologize if I went a little over.
Okay, yeah, thank you for the really interesting talk. It's really cool to get a much more clinical perspective on all of this, coming from more of a neuroscience-y, bench science-y background. Tess, is it possible for you to put us into like a different view so we can see everybody all in a row? I want to do a show of hands here to
So I think
get a
everybody
sense
has
of-
control over the view themselves. So if you go up to the top right of the screen, you'll see view.
Okay. So yeah, so everybody go into gallery view for a moment, and just raise your hand using the little raise hand emoji if this if these ideas of mechanical basis are something that had crossed your path before, whether you're a clinician or a scientist. We're very curious about how well known this has been versus more, pharmacological or molecular based perspectives. So I'm seeing a lot of hands. Okay, that looks pretty good. That looks like probably pushing half. And so one of the things that we were very interested in, coming out of the molecular basis of ME/CFS is how, we might be able to link some of these more macro scale perspectives to the micro scale, molecular biology, cell biology, and biochemistry that is often talked about. So I have two questions for our speakers, and then we'll open it up to just a general Q&A for participants. And then the three of you guys are welcome to hop in as you feel is appropriate. In the chat, the question of how any of this relates to post-exertional malaise came up. And, PEM is sort of this very unique, very unusual hallmark feature of ME/CFS. And so, Jeff, I know you've had some ideas in this direction, but could you talk a little bit about how mechanical brainstem deformation might lead to this very stereotyped and very unusual presentation of PEM?
Yes, absolutely. And I had actually included a slide on this, but then I lost it right before my presentation. So the way that I conceptualize PEM as it relates to the mechanical basis model is kind of simple. So let's see, I think Herbert Rins-Polster asked a question in a specific way that I feel I can sort of springboard from in order to answer this. So he wrote, I agree the brainstem is the main regulator of all that is broken in ME, but we need to understand why the brainstem seems to work okay at some times and fails to do so after exertion of any modality, right? And I thought about that, and I thought about something Michael said. Okay, so to answer that question first, with motion, our craniocervical junction moves. With physical activity, if I get up and walk, I'm moving. And I felt it when you have craniocervical instability, you feel the motion. You know that your skull moves, and you know that your neck moves when you do things, right? And it could be something as simple as looking down to cook. It could be chewing. You're moving, all of that, and that entire joint complex is very sensitive, and it's involved in almost all motion. And I think, as Michael indicated, he showed imaging of when somebody breathes, the brainstem is mechanically, I won't say deformed, but there's motion. So we can presume that in somebody with CCI, there is more motion on the brainstem with movement, even movement as slight as breathing. Okay, how that would relate to PEM. If you're beating up neural tissue, the neural tissue will likely swell. The body's swelling response peaks 24 to 48 hours later after an injury. If you put too much mechanical pressure on that brainstem, you're beating it up. And the timing of PEM actually reflects the body's injury response quite well. So that's sort of my conception of PEM. And it's just, to put it in just very, very basic terms, you move too much, you exert it too much, you beat up your brainstem. Your brainstem is going to be swelling, and it's going to peak 24 to 48 hours later. It's going to make you feel really sick. And then over time, you will slowly recover to baseline, hopefully. So that's how I conceive of PEM. And it's sort of, I don't know if that's correct, but that's what I think is correct. I would love to see more studies. I think we would all love to see this. We want to see people research the hell out of this and solve this quickly. But sort of in that same vein, I only mentioned that, PEM can be temporary, but there are some times when a person will overexert and then their overall baseline decreases for the rest of their life in some cases. I always try to think about why. And my conception of that, and again, this needs a lot more study. I could be totally wrong, but I believe that it's because with motion, you're not only beating up your brainstem, right? You are putting stress on the joints, the craniocervical joints that are already compromised. And it could very well be, and this is speculative, but that when you move, you're degrading the joint complex that is already in the process of degradation. And therefore, your CCI becomes worse during exertion. And now you're going to crash, and you're going to crash harder. And you're never going to regain your previous baseline because your craniocervical junction is now never going to go back to being as stable as it was.
It may, just from an analogy perspective, it may be helpful to think of an analogy of a blister on the back of a foot with shoes and rubbing on that. And if I get a blister on my shoe and or my foot, and I keep wearing that same shoe and don't have a sock or don't have a tighter lace, it'll just keep getting worse and worse. If I do it over a very long time, it'll turn into fibrotic scar tissue. If I don't have good blood flow in there, it won't. I won't be able to heal it. But early on, if I protect it, if I get flow in there, it will heal and it'll go back to where it was. And that same kind of local mechanical inflammatory response with nutrition coming in and waste materials going out is likely a plague throughout the body.
So Jeff, I know you've seen this in the chat, but I want to bring it up to everybody. You know, the obvious next question, I know we've discussed this, the two of us, is what about PEM associated with mental or emotional exertion? You know, there are plenty of people who've had experiences of crashing after trying to watch a movie, you know, or engaging their brain more than they're capable of. And I don't know what the obvious sort of mechanical, physical deformation is there.
Yes, it's a very interesting question. And one way that I think about it is when we have emotions or deep cognition, we are usually changing our breathing. We are often, if it's emotional PEM, sometimes it's because we're having an emotional discussion with somebody, you know, and so we might attribute it to the emotions, but it could very well be it was the breathing pattern. It was the way we moved our head when we were talking. We were gesticulating during the emotional discussion. So that's for people who still have some degree of function, right? When we get down to, I mean, some people, the really, really severe spectrum, they can get PEM from a smell. They can crash from, they can be presumably lying in place and crash. So I think due to some sensory input, what I believe about that level of functioning, a patient that is that severe, if they were to move, their PEM would be even worse than it is simply lying there being subjected to a sensory stimuli. So I guess it would sort of go like this. Exertion will cause PEM in all patients at all levels of severity. Exertion will cause the most severe form of PEM relative to, say, sensory input in the most severe. It could be that and I don't know, but it could be, and that's something Mike was saying made me think of this, is that when we have a signal propagation, so let's say we're exposed to a smell or a bright light, a signal needs to propagate. And if the area is deformed, we are going to have cellular processes, we're going to have molecular processes, we're going to have signals. It could be that the signals actually chemically leave there being a problem. In other words, they cause swelling just on their own because they're so malfunctional. I don't know that that's true. I don't know how that might work. Mike would probably have a better idea of that, but something about how the neuroanatomy cannot recover after a stimulus. And in the most severe, even if that stimulus is non-motion based.
So Mike, I see you have your hand up, so I'll just pop right over to you. And then Brayden afterwards.
Yeah, so I think this is an example of the sort of like, I think, diagnostic creep that's happened with the ME field that we have to take note of. You know, Melvin Ramsey describing PEM was describing a very specific thing, and he was largely focused on discrete outbreaks where people in those discrete outbreaks probably had the same problem. You know, now with the diagnostic criteria based on symptoms, we're probably collecting lots of people that have different causes, different issues driving to this endpoint in which they fulfill criteria for, either international, Canadian, whatever criteria. So that's worth noting. When Melvin Ramsey described PEM, he was describing something particular in the muscles that people felt when they exerted themselves, sort of physical exertion. So, what PEM has now been sort of expanded to include is, a difficult Sudoku or something. People have these conversations where there's a lot of lights and a lot of background noise, and that gets sort of overwhelming, and that's a little bit closer to something that you might see in a post-concussive syndrome, where about 10% of people of more severe concussions end up with seizures, and that is thought to be largely related to that phenomenon that I talked about of glial priming, in which glia that are activated produce neuroexcitatory modulators, glutamate, bradykinins, prostaglandins, all kinds of things that excite neurons. It's part of why there's sensory sensitivity. If you have someone that's just had a concussion and they walk into a Walmart or something, they feel really overwhelmed by the lights and the sounds and the movement. That might be something a little closer to what's happening to people that feel overwhelmed by something that not non-physical, something other than having to go walk around all day or something. It may not be the exact same mechanism. I mean, David Systrom at Brigham and Women's shows that in the more sort of physical exertional sense of PEM, at least a subset of people just have reduced oxygen extraction, further out into their vasculature. That may be lack of perfusion and that sort of thing. But so I think it's important to note that we may not be talking about one thing that we're calling PEM. It may not be the same thing mechanistically.
And Brayden, do you want to follow up on that?
I get sensory stimuli overstimulated in Walmart too with that blue color and the fluorescent lights. I wanted to bring attention to the idea of PEM here and say, I think from the clinical perspective, what we've observed is maybe a little different. As I touched on in the talk, there are people who end up in post-exertional malaise even after what we think are definitive treatments or fusions where there isn't motion, at least at the level that we're most interested in this case. And is there some other neuroanatomical complication, something with increased cranial pressure? Maybe. But when you look at how we train people to stay out of PEM, when you look at things like pacing, for example, people will do things like exercise for very, very short amounts of time while monitoring their heart rate and their heart rate variability. And if they stay below a certain heart rate and they stop and bring their heart rate back down to normal and rest and put their legs up and support their circulation before they start exercising again, they can do things with movement on and off, on and off, on and off, and not pass that threshold for post-exertional malaise. So I think that PEM, if we understood it completely, we would understand this illness better. But it does feel like an altered physiological state that is affecting metabolic and immune function, and it can be triggered by CCI in motion, but I think it has other external triggers as well from what we see clinically. And I would just also comment that not only can we see inflammation 12 to 24 hours later, but we can see gene expression change 12 to 24 hours later after an initial insult.
Awesome, thank you. So I have one more question, and then we'll open it up to Q&A. This is for the panelists. We're talking a lot about these different conditions like CCI, atlantoaxial instability, Ehlers-Danlos. The vast majority of individuals with all of these conditions don't develop any CFS. We know that they're highly comorbid, but there are plenty of people who live their lives with, connective tissue disorders and never get ME. Do the three of you have any thoughts on why? What is happening here that sends some people down this catastrophic new trajectory that is not necessarily determined by the comorbidity?
Yeah, I mean, that is the $64,000 question, right? I mean, that even in terms of EDS, that label gets put on a lot of people that don't have an obvious genetic EDS. They're sort of known genetic EDS. And again, that label has been expanded a little bit to include people that are hypermobile, it seems to be a vulnerability, but then some of the best athletes in the world are hypermobile. Michael Phelps, Simone Biles, these are extraordinarily healthy people, much healthier than I. And they have, what one might call EDS. So it may be the case that there is a vulnerability in the connective tissue from my perspective, and I tend to be a little bit more focused on the contribution of pathogens, given that we are not sterile. Human beings are not sterile. There is a Serengeti happening inside of all of us at all times, massive amounts of viruses, bacteria, all the time. These are organisms that, if they are successful in a mammalian host, largely have evolved, as Jeff mentioned, to modulate matrix metalloprotease expression and to burrow into tissues, many of which need to be in tissues to work. They're kind of like parasites, especially viruses don't have their own metabolism. They must hijack host cell. So it may be the case that there is a vulnerability in which, if someone has a hypermobile phenotype, they may have an easier penetrance, or their connective tissue may be more easily degraded once that infectious process takes hold. Again, it doesn't necessarily mean that they are riddled with pathogens. Epstein-Barr is in most of us, and it will cause multiple sclerosis in a very small number of us. It's not Koch's postulate from 1890 where one pathogen, one disease. So I suspect that there's vulnerabilities. And again, I think of it in terms of drivers to an endpoint, where there's this endpoint of a clinical phenotype of subjective symptom expression. And I think that you can probably get there in many different ways. Unfortunately, I wish I was wrong about that, but I think it's probably the truth is that there's not going to be one answer for people with this diagnostic label.
Okay, so now let's open it up to Q&A, and I will try to keep track of everybody. I'm going to try to get people who are outside of the Renegade research group first, and then we'll add in more of us as time goes on. So I think John Houghton. You're muted, John.
This idea of vulnerability and multi-paths into that vulnerability resonates with me. So is it an inflammatory viral, or is it a blood flow waste removal, or is it a mechanical impact and movement? That all those things can stack on each other to get you past a threshold of available energy, available use, and you're kicking over that. And in a lot of these things, we see changes in the TCA and glycolysis. You see changes in M1, M2 white cells, and so it is the clinical attack trying to get at these different dimensions. And if you get a few percent of one and a few percent of another, that might work in one person. And if you get a bigger majority of one in a different person, that might matter, or somebody's genetic predilection towards it. So I'll stop there, but that the concept of a core underlying process that roots in scar and fibrosis, that there are a lot of different ways to get into it.
So then Herbert and then Jake.
Okay, two comments. One to Michael VanElzakker. I would certainly try to question if we should really distinguish the real PEM, which could be triggered by physical exercise, and other forms of PEM. As a patient, I can tell you it's all the same, and no matter which modality triggers you, be it emotional, mental, cognitive, physical, orthostatic, or whatever, you end up in the same situation. And I think it's also not really covered by research. I think you can do cognitive stress and you find the same MRI or connectivity issues as you do with physical exertion. This is the first thing. The second comment would be, I think we all agree that the brainstem plays a pivotal role in ME/CFS and related forms. But I think the missing link is really how could this explain ME/CFS? And I'm sure we could do an experiment. We could possibly paralyze muscles in a patient, in an ME/CFS patient, without any motion to your brainstem whatsoever, and then put flickering light above that patient. And I'm very, very certain you would elicit post-exertional malaise. So we need to keep in mind that the brainstem is certainly not only prone to be manipulated and affected by mechanical effects or triggers, but also by immunological or inflammatory signals, as you laid out, Michael. And that may be another, or at least in many patients, that may be the trigger. That's basically my two comments.
All right, Amy Hyde-Smith.
Hey, yeah, this is Amy here with Dr. Gillette's office. So we're seeing in our office that with some ME/CFS patients, specifically those who may have been exposed to, say, mold or might have a lingering Lyme infection. Even patients who, after some kind of either tethered cord release or fixation, tethered cord release or fixation, if there's still an ongoing infection response or a post-viral response, even in some not so much with long COVID patients, but especially in those who are still continuing to have the inflammation response, that even after the mechanical issues are treated, quote unquote, that they may continue to see adjacent level syndrome. They may have higher frequency of retethering. And so I'm really interested if anyone has, we're on our side, we're looking into some of the treatments Dr. Yellman discussed, looking into IVIG, looking into some of those other treatments that would help those types of patients to have better outcomes either before or after surgery. But I'm really interested if anyone's having any kind of success as well in patients who are still dealing with ongoing infection cycle or inflammation cycles. Just interested if anyone has any input on that.
I'll take that one. I think that in most of these patients, there are multiple mechanical problems. And if we can assume the patients have a connective tissue disorder, then we can assume that they will always be vulnerable to some extent to recurrence or to some of the symptoms just not going away. But what you mentioned in terms of preventative measures, you mentioned adjacent segment disease, which is, I think most people know, but it's when somebody is fused, say you're fused skull to C2, your C3 and your C4 and your C5 now are at risk of becoming unstable because they take all the mechanical load that your craniocervical junction had previously shared. So adjacent segment disease is a known it can be a consequence of a craniocervical fusion. So it's just kind of a given. It's one of the risks going into the surgery. A way to prevent it, or to at least help make it less severe, I believe Dr. Yellman talked about prolotherapy. There are non-invasive ways to bolster the connective tissue. That would be one way to address potential adjacent segment disease. But there are other pathologies here beyond just that can crop up, that can recur. So, for example, when I shared the cervical stenosis slide, there was a patient who had a full recovery from ME following a cervical fusion. And then a few years later, the level beneath that fusion stenosed. And that's actually different from adjacent segment disease, but it's sort of the same concept of connective tissue disorder patient is like a domino. It's like their body's just a domino, a set of dominoes. And okay, so So yeah, I don't know. Yeah, I think ideally we would just intervene at the level of the connective tissue itself, find a way for the connective tissue to become more normal. I think that's the long-term goal that could prevent a lot of this stuff.
Brayden, do you want to follow up on that?
Yeah, full disclosure, Amy and Dr. Gillette's office and our office have worked very closely on some patients, of course. But, I agree, Amy. I think that, even when we try to model out ME/CFS, a lot of models that a lot of people carry generally start with some kind of immune insult and a dysregulated immune response, whether that is an infection, whether that is pregnancy, whether that is a traumatic brain injury. And that infection, of course, doesn't have to be viral, for example. And the response to that, for whatever reason, whether it's epigenetic, whether there are risk factors genetically or from connective tissue, et cetera, that there's this really dysregulated immune response with some active areas of overactivation, some of underactivation, areas that should not be activated, et cetera. And that starts to trigger a cascade that leads to all of the other things that we are seeing in the full-blown syndrome of ME/CFS later on. And so, of course, when we think about healing people from CCI or tether cord surgeries, we want to regulate the immune response as much as possible so that we don't end up in a path like that. Again, clearly that immune dysregulation plays some role in driving the symptoms, in addition to the, I think, mechanical issues that are here. And some of those mechanical issues, in many cases, may arise from this immune dysregulation many, many steps down the road. So when I've sent patients to your office, I generally think about, are they having any kind of viral reactivation or chronic Lyme inflammation or other sort of hidden or occult infection that we need to keep from triggering the immune system? Do they have uncontrolled mast cell activation, which of course doesn't need an infection to continue to smolder and go wild? So what can we do to suppress mast cell activation as much as possible? How do we keep people pre-surgically and post-surgically from having this type of immune dysregulation that may contribute to worsen post-surgical outcomes? It's something that we're always thinking about, and I'd love to see us get better at managing those aspects of the illness if this is going to be a definitive therapy for people and really successful long term.
So that brings up something that I would be interested in asking to the whole group. Is the question of feedback loops. We're talking a lot about this one particular kind of injury to the brainstem, but you could imagine that you have some kind of injury to the brainstem that triggers just some kind of dysregulated immune response, which then triggers Epstein-Barr virus reactivation, which itself then causes problems down the line, right? And so this general problem of how do we tease apart first order effects, second order effects, and then the orders in which we might want to address those. I think that's going to be a really big issue going forward. And so I don't have like a particular question. That's just something that we've talked a lot about internally at Renegade Research. And I would like to get out there for people to chew on. Bo?
I have to say something on that. In terms of the feedback loop or the order of things, I've known 2 patients who had chronic reactivating viruses based on viral, as measured by viral titers. They had craniocervical fusion surgeries and their titers normalized. So, and interrupting that, that signal killed that, killed the, I can't really talk today because I didn't sleep last night, but that is one direction that problem was taken care of.
Interesting. Bo, you have your hand up.
That's right. I was just thinking about the question about medical non-surgical treatment of these kind of problems, and if we have any experience, and at the Brigade clinics in Stockholm, we've tried a lot of different things because no neurosurgeon in Sweden will want to do anything with these patients. We have the same experience as was explained by Brayden. We see all these disturbing flow in the spinal canal, and they are called just functional. But so we have tried a lot of things, and you know, whether it's a mechanical or a chemical initiated neuroinflammation, the cytokines are very much at the root of this. So one thing that we have tried and seen some positive effect is anti-cytokine antidote, like you know, infliximab or even cortisone and such simple things like doxycycline, which is a TNF alpha antidote, which many don't recognize, but it is. It was shown already 30 years back. It was 35 years back. They showed that doxycycline has a TNF alpha antidote effect, and TNF alpha is probably one of the most potent the cytokines that are involved in many of these cases. So this has sometimes had a fantastic effect, and some of the patients have come to notice this because they've been given doxycycline for something completely different, some infection in their throat or something, and then they just happen to get well from their ME CSF. And but I've seen it in 35 years. I've seen it, and we don't have any publication on this because we haven't done it as a research project. It's just clinical experience.
Thank you. So Thomas actually had to leave, so I'll take over. I will say, you know, we've been going for 2 hours. We decided that we will go as long as people are willing to keep talking or interested. So I'm going to keep doing that. But, you know, if anybody has to run, feel free. I'll also mention that we are going to have a part 2 of this meeting because we had so much interest. It'll be November 1st at 1 p.m. Eastern time. And I really do want to try to make these connections between the molecular basis. So I'm hoping that in that meeting, we can spend some more time on, maybe we can have some people present some of the presentations that they did at Ron's conference, and we can talk more about that. So if anybody wants to present, reach out to me, tess@renegade-research.org, and hopefully we can have a really good second meeting. So Michael?
Hey, I have to run to another meeting in a second, but I just want to mention really quickly, sort of interestingly, I think, you know, I think the way that I think about this for a lot of people is kind of like unpeeling an onion, where they have multiple sort of overlapping, cascading issues that need to sort of be dealt with, and they probably compound. Sort of almost the inverse of what Jeff said, which he's completely right that you know, physical stressors can trigger viral reactivation. Even things like space flight can trigger Epstein-Barr reactivation. There's a 2018 case study from Moyazani and Breischwart that showed that a veterinarian that had an apparent, you know, it was presenting like a hypermobile EDS, and it turned out that he had this veterinarian had a Bartonella infection. And once that was dealt with, the EDS actually seemed to resolve. So it's another example of this sort of cascade to an endpoint that, you know, if someone has their brainstem being compressed all the time, they're probably not going to get much better. That's like a serious insult. So it's kind of unpeeling an onion. People may have, you know, cysts in their spinal cord, and they may have some particular infection that most of us who are healthy sort of deal with and contain. And so I think that's what we mean by complex when we talk about complex illness. So anyways, thanks all. I have to run, but thank you very much.
So Rochelle just told me that Eric has been trying to speak for a while. So I'll go with him, and then we'll go to you, Jake.
Yeah, just that this comes down to, I mean, I keep saying it's chronic inflammation. I said I'm a great devotee of Dr. Navio's work, because we see it all the time, is that complex illness, and a large number of them have mild forms, to severe forms. We do send a few people to Dr. Bolognese, but a lot of them, when they're inflamed, their ligaments get more lax and they get into trouble. And yes, we can quiet it down. We use peptides and all kinds of things to quiet down the inflammation. But at the end of the day, it's treating usually the underlying, it's usually infection. Now, the unfortunate thing is that once your body has learned to go to a rapid inflammatory response, like you see with MCAS, because again, MCAS, for most people who don't have it very young, it has been induced by a low-level chronic inflammation. So the difficulty is in medicine, the idea of treating chronic infections is, really not paid much attention to. EBV, CMV, Lyme, and all the co-infections, and they're often underneath, the sensitivity to mold, which then often will come response to your brakes aren't working. So once you get inflamed, the normal person, you have that really severe inflammation that first 2 days of a flu, but by day 3 or to 4, you're starting to feel a little better. That's what chronic fatigue often feels like, is that it just doesn't go away, because you can't tamp down. And when you're inflamed, when you are infected, your mitochondria change, and they're no longer able to produce energy they've chosen not to produce energy for you. So you're left burning sugar, which is a good short-term solution, but not a good long-term solution. And so, when you have cognitive stress, you have to use your brain. Your brain is a tremendous, it's like your heart. It has thousands of mitochondria per cell, not hundreds. And so if those mitochondria in some part of your brain to a loop, and you're going to, so that brainstem isn't going to work well. If you, just focusing your eyes takes a tremendous amount of energy. Those nuclei that control eye motion are very, very mitochondrial dependent. So that's where flicker will really trigger people, because your eyes have a lot of work to do when there's light flickering or you're moving your head fast. So it just comes down to this, as Dr. VanElzakker said, it is an onion. You have to peel the layers back, and you have to support the body at the same time. You do your best to find whatever the irritant is. And I think until we learn to parse our patients, the ME/CFS research is going to be crippled, because we're looking at different situations. It's your biochemical individuality, your genetic individuality, that is going to depend on the different response you have to the infection, because many people have all these infections and get over it. It's not the bug, it's how your body responds to the bug. Anyway, long story, I don't want to go on and on, but once your craniocervical junction, if you have EDS or some kind of connective tissue issue, most of them don't have real EDS, then you have another level of problems. And so I think it's crucial that we not forget that, but we've got to remember what's underneath it. So, okay. Thank you.
Jake, did you still want to go?
Yeah, so I was just gonna add, I think one way to possibly look at why there's a difference in some EDS patients, why some tend to develop ME and some don't, is maybe just from a how many knocks to the totem pole they had in their life sort of perspective, where it's Have they been exposed to molds? Have they been in sports where they had just a lot of minor injuries? Have they ever had traumatic injuries, traumatic brain injuries, whiplash injuries? I mean, like car crashes are pretty common, sadly. And so like there's just all these sort of things that can play a role on the spine, that like we might not think of is each individual event being some sort of catastrophic event, but all these things could add up over a lifetime, whether it's through these literal physical mechanical forces changing how things are sitting, or if it's like, you know, you get this injury that slightly raises like MMP9 or something, and then it stays at that sort of elevated state. It elevates again after another injury or something. And then it's just continuous thing that can raise and raise and raise after we've added more knocks to the totem pole. And then I think that's, I don't know, I guess it's just like a good way to perhaps look at how there could be a difference between some EDS patients just by like chance. There could be different triggers. Obviously, socioeconomic things will play a role in this. Yeah, that's it.
Josh?
Hey, yeah, that's I think that's really thoughtful. And as a patient that's had TC and surgery twice and CCI that's failed below, I'm consistently wondering what causes relapse. And I think everybody, you know, Eric has seen it. People get surgery and they get better. My PEM went away and it comes back. Trying to figure out like I actually have a friend that has very classical hypermobility EDS, and we share the same fusion. She does not have PEM. She's like subluxing her hips and her elbows are blowing out. But PEM is this very unique response to it for this subset. And yeah, and we desperately need answers, or we're all just going to fuse to death. You know?
Yeah, agree. Anybody else want to go? I'll mention, as far as making these connections, I think the innate immune system activation is one of the keys. I think, you know, with Rob Fair's attack innate shunt hypothesis and the cell danger response hypothesis related to the immune system, that can be triggered by the brainstem. And so maybe you don't even have an infection, but you have sort of these deformation stresses happening in the brainstem, and then that's triggering the immune system. And also related to the sickness response that Michael VanElzakker mentioned, you know, evolutionarily, the brainstem, he mentioned that this is the center that brings on sickness response, sickness behavior, and there are downstream effects from that are evolutionarily adaptive. So, for instance, hypercoagulability is one aspect that can actually be adaptive to infection. So you can imagine, you know, all these adaptive effects could be there to deal with infection when it's happening, which affects the brainstem. But if you just have the deformation, it could lead to the same sort of downstream effects. Jake? You're on mute.
Sorry, I just wanted to add something that I don't think I mentioned before. But you can get Chiari tethered cord, likely CCI. I didn't find any exact documentation on it, but it makes sense again in this model from just a car crash. So you can have something that significantly alters the brainstem from something that's not super uncommon. Like it's pretty common to get into at least one fender bender in your life. So it's just, you know, it's an additional variable where it's something that you can go from thinking it's just congenital, but realizing that like there's a significant risk factor for a good population of people to develop this. And I know Brayden sort of touched on that in his presentation as well.
I can't remember if you went into it, Brayden, but Jeff brought up the anecdotes of patients having like viral reactivation that then improves after fixing CCI. I'm just curious if you see that sort of stuff in your experience with your patients.
No.
Okay,
And
interesting.
so I think the problem is that what do we mean by viral reactivation and how are we measuring that? So, for example, for a while, I think a lot of clinicians have followed Epstein-Barr virus titers, and then they see how they respond to things like antivirals, valacyclovir, famciclovir, valganciclovir. And occasionally we see improvements in the overall clinical syndrome with those antivirals. And so you would expect that that would correlate with a decrease in viral antibody titers. And there is no correlation. People go way up, and you're clearly suppressing sort of a secondary viral reactivation. And I often think about, certainly, Epstein-Barr virus has been a thoughtful trigger for people, but I don't think that it's necessarily, could be, but I don't think it's necessarily right for us to assume it's always driving the immune perturbations. In fact, I think what I generally see clinically is that people, when they get into a place of post-exertional malaise, or when they're fighting off other infections, when their immune system is otherwise occupied, it can no longer keep these type of reactivating infections, whether they're intracellular or viral infections, at bay. And then they have a secondary reactivation that drives additional symptoms and may be part of that PEM presentation in particular. And so we still see those symptoms pre and post surgical intervention, pre and post fusion, unless we are actively trying to prevent them, whether it's via pacing, whether it's via antivirals, et cetera. So I struggle to believe that by fixing the neuroanatomical complications that we're really affecting things that live in the dorsal nerve roots and how the immune system interacts with them, for example. It's not impossible, but it's certainly not the way that I've come to see it just from clinical observations there. It was interesting, though, to hear Dr. VanElzakker mention the story about Bartonella, which I'm learning is actually really common in veterinarians of all people. Like 50% of them have latent Bartonella. But it is true that certain latent infections or reactivations do drive worsening of connective tissue disorder, and that when you sometimes get on top of those infections, that we do sometimes see the ability to heal or improve from connective tissue disorder in a way that we couldn't while there was that active issue there. So that may tie into the issues that we're talking about here neuroanatomically and our ability to manage them conservatively or even heal and strengthen around an area of fusion so that we don't have lower areas of herniation, for example, in that post-surgical period.
I'm kind of curious, we have quite a few other clinicians in the room and some people involved in neurosurgery. I kind of want to ask you the same question. Do you see changes in labs and biomarkers after surgery? People improve in symptoms, but do you see anything objective? If there's anybody else.
How many clinicians are regularly measuring viral titers? Because the way that I knew that mine had resolved was I was getting every 3 months, Dr. David Kaufman would measure my titers, and they were positive for years. For all the years I was ill, they were positive for Epstein-Barr, IgM, and IgG. They were positive for parvovirus, mycoplasma pneumonia, a bacteriological infection, chronically positive, both IgG and IgM. I had my fusion surgery. The next 2 months later, it was actually after Dr. Kaufman drew my labs and they were normalized and they remained normalized. Okay, so that's me, that's one data point. But another data point came along. One of my friends, Jennifer Brea, she's open about this. Her viral symptoms appeared to normalize. She would get monthly outbreaks of cold sores in her mouth. After her fusion, that went away. So these are 2 data points, right? But it does make me wonder how many others might be experiencing this. And if labs are being drawn every 3 months, which frankly might be overkill, but it was very illustrative for me.
So, I certainly don't want to have like a back and forth, like an argument. By no means am I trying to do that, but just sort of the things that I would wonder about or observe in that case. For example, the oral ulcers, that is very much often something like an HSV 1 or 2 reactivation in many cases.
Right. Talking about the viral activation, right? So we're on
Yeah,
the same page.
so-
I'm thinking we're on the same page. I'm not trying to fight with you either.
I think, oh, neither am I. I didn't want to make it seem like I'm attacking by any means, but I guess the way I think about it in that case is, you know, if the main driver of your symptoms is indeed craniocervical instability and neuronal deformation, for example, and that is triggering secondary immune response, and you remove that primary trigger, you're not going into PEM anymore, right? A lot of people respond, they're not having PEM after these successful surgeries. If you're not going into PEM, you're not putting yourself in that vulnerable state where you get that viral reactivation in the first place. So the lack of oral sores, for example, to me would be a lack of HSV reactivation because your immune system is not otherwise occupied and constantly reacting to the mechanical stressors that we talked about today, among other things.
Yeah, I think that we might be talking about the same process, which is that when the mechanical problem is taken care of, you no longer go into PEM, and that allows you to not have viral reactivation.
I think that could certainly be true in some cases.
Yeah, and I believe it would be modulated, perhaps. Yeah, sorry.
Somebody, no, I have to go. It's a circle. You know, I mean, the immune system talks to the brain controls the immune system. If your, you know, vagus is happy, your immune system functions better. You know, I mean, so it just depends on what's weighted in you, and that is our problem. Let's remember that this is a disease of the individual. This is not a bullet where everybody gets affected the same way. This is so much your illness. So there is going to be a subset of people who you fix their neck and they get better and they stay well. And then there's a lot of other people who you fix and they get partially better because that wasn't the main driver. That was a secondary piece. It just depends on the individual. And I think we have to remember that when we're dealing with this illness, that, you know, what worked for your cousin might not work for you, or, you know, your best friend. And I mean, this is the problem with medicine. We always have that. People come in, well, my uncle took this.
Oh, totally. You know, and I think when you remove mechanical pressure on 2 areas that regulate the immune system, yeah, like the brainstem. I'm sorry, I cut out.
Just the person you read on the internet, and
you're kind of cutting out, Eric. So
yeah,
we can't really hear.
Help.
Yeah. So I was just going to say, yeah, when you remove mechanical,
I just wanted to just make the point that I don't think there's any argument. It's just people are different, and we don't lose that piece of how different we all are. Because I think that's really trying to find the one cause for this illness. I think is going to has been driving people crazy forever. You know, this isn't a strep pneumonia. You know, it's other things are happening. I can see Brayden is thinking.
I was just going
I agree. Apologize for.
I agree with you, Dr. Gordon. It's a very heterogeneous presentation and illness, and you do have to think about everybody individually and manage them all different. I have no particular process that I follow that is the same for everybody. It is unique in that way. The other thing I thought was worth maybe commenting on, just as a way to kind of to think in those terms, to say, hey, is as much as we want to find a unifying theory, we also have to think about individual circumstances and all the variables that play into that. When we talk about, you know, viral antibody titers, having antibodies requires an adaptive immune response and a whole lot of triggers all the way through B cells releasing those antibodies. And so it begs the question, what is going on upstream that is allowing us to see these antibody titers as well? It's not necessarily, because we've tested with PCR, it's not necessarily active full viral replication. And I know there's some really good studies by Dr. Prusty out there about how you can have sort of a partial reactivation without full viral particles, just certain elements of their RNA, for example. But what I'm getting at is that the absence of those antibodies may be because the upstream immune reaction that was triggering that secondary cascade and that secondary adaptive immune response. The thing that was pushing that initial immune reaction may have been the mechanical forces at the brainstem. You remove that, and now you're not seeing the antibody production as a kind of a tertiary consequence there. On the same end, though, it doesn't mean that the viruses are not still latently, living in the nerve tissue and that they still can't reactivate in other forms of physiological stress down the road. So just kind of a word of caution in that, how we interpret things.
Yeah. Bo, did you want to go still?
Yeah, I think the question was posed about how often do we take samples and before and after surgery on immune things or proteomics or metabolomics or inflammation. I would say it's very seldom. It's very, very seldom that a neurosurgeon will be interested in any of these testings before and after. However, we have now an ethical approved study here in Sweden where we will make numerous tests, not only in the CSF, but on blood and saliva and almost everything we can before and after surgical procedures of the cervical spine. So but it's been a very difficult thing to get these approvals. So, and now I have to leave, but it's a very interesting discussion you have. So thank you for letting us be part of this.
Thank you for coming.
Thank you. Bye-bye.
Anyone else have any other topics? Sorry? Does anyone else want to go?
Oh, if I can just chime in on testing before and after surgery, checking biomarkers and immune response. That's why I think these kind of conversations are so important. It's a multidisciplinary approach, I think, is crucial because your neurosurgeon is not a rheumatologist. Your neurosurgeon is not an internal medicine specialist. And so it's so important that we do cross trainings. It's so important that we have these discussions. It's so important that we have form relationships so that we can broaden our understanding and our collaboration because we're dealing with such a broad, a global condition when we're talking about ME/CFS that touches almost every system. And so it's really important to continue collaborating and to continue building these relationships and appreciate like platforms like this and relationships because when we're talking specifically as neurosurgeons, our knowledge is and our impact is limited, and just as Dr. Gordon was speaking about, a lot of times it also there's a financial factor that comes into account as well, is that it's difficult to order these tests financially, and insurance doesn't cover them, or if you're dealing with a private doctor, there's those issues involved. So having support of a local medical team who collaborates with the neurosurgeon is also so important. Even beyond surgery, just looking at a diagnosis to then kind of support to prevent a patient needing surgery is so important to involve the local GP, the local rheumatologist, the local internal medicine specialist, cardiologist. A multidisciplinary approach is so super important, and that can be for us in Barcelona, where the majority of our patients, 90% of our patients, come from outside of our location here in Barcelona. It's so challenging because we can only do so much, and so that's why these collaborations are really, really important. And I just want to say we worked a lot with Bateman Horne Center, and we're constantly looking to work with other collaborative clinics who work with ME/CF patients, so we can expand our treatment of patients beyond just surgery. Prevent them from needing surgery is really the big goal. But those who do progress and need surgery, that's not the end of treatment. For most patients, surgery is not a cure. And so these collaborations and multidisciplinary approaches are so crucial.
Agreed. Julie?
Yeah, I just wanted to particularly in talking about individual variability, I think a really key part of this is finding all of the different conditions that a patient has, particularly I'm thinking in terms of like, the mechanical perspective alone. I think, one of the things that we've found just in the patient community talking to one another as we've, for those of us who have pursued neurosurgeries, is that until you address all of the problems, then you may not see that much benefit. Certainly we've seen that in terms of tethered cord, very often someone will have fusion, will start doing better, and then will start declining again with many of the original symptoms and do quite poorly until they have tethered cord release. But that's far from the only thing. And part of what's difficult is that we don't have like a central place you can go to get all of these issues diagnosed. So, abdominal compressions play a role. Jugular vein compression plays a role. Cerebral vascular issues play a role. And actually, I was gone in the middle of this webinar to meet with Dr. Hepworth about cerebral vascular issues, which it turns out that I have, and that's probably part of why I'm doing so poorly. So, I think that part of what we need to do just on a practical level for patients who are at a point of pursuing neurosurgery, or at least trying to figure out what all the issues are, like we need a clearer pathway through so that like right now we're still at the stage where we're kind of figuring it all out, and like you do a neurosurgery and then you're not doing so well, and then what's the next step? It's really unclear at this point. And I do think we're learning as we go about what all of the different conditions are that can produce problems in the brainstem, and all of the cascading effects from that.
Yeah. Hepworth's actually my surgeon. He's amazing. Let's see. All right, seems like maybe, oh, Ellie, you're on mute.
I was wondering if this is a good time to bring up the Cells Talk cytokine encyclopedia website if people don't know about it. cells-talk.com. It's a huge treasure trove of curated information about cells and cytokines that's written by a retired man. I can't remember. If you go to the HTTP, not the S, cells-talk.com, it has a whole explanation. He hasn't been able to update his site. Dr. Afrin is the one who writes about it in his book and spoke about it during his roundtables, that it is the best source of mast cell information, mediators, receptors, and he's afraid that it is going to go away because it's not getting supported enough. So we've been trying at Renegade Research to try to let people know about it. And if they need somebody else going through the research papers and collating all the stuff about mast cells or whatever else you want to know about cytokines, there is a place. I'll try to drop the link in the chat.
Thank you. All right. My son is about to do a fun run at school, so I think that this would be a good time to wrap up, and I could follow up with everybody about part 2. But this is really, really fun, and thank everybody for coming.
Thank you, everyone.
Bye, everyone.
Bye-bye.